You would require blood cultures, you would require renal function tests, you would require cultures from septic emboli sites, an ECG, an echo, a multi-slice contrast CT in case your patient has developed neural manifestations, and a chest X-ray. So now, then we talk about, you're talking about blood cultures, what is the actual instance of blood culture negative endocarditis? Now, when we talk in terms of Indian data, blood culture negative endocarditis is to the tune of 48 to 50%, whereas blood culture is sterile in 31% as per Western data. In recently published data, what they have observed is roughly up to 1/3 of these cases, 1/3 or 16.7, 1/3 or something like 33.3% of the cases, you get a culture negativity in published data from India. Common causes for this would include antibiotic therapy before actually blood cultures are done. Then you have endocarditis secondary to fastidious or atypical organisms which do not grow in routine culture media. And you have fungal or viral endocarditis. Excuse me. Now, these are the certain lab manifestations which you can see on further testing. You can get anemia in these patients up to the tune of 70 to 90%, leukocytosis 20 to 30%. These patients may have microscopic hematuria on urine routine. You can get elevated ESR in more than 90%. You can get a positive rheumatoid factor in 50%. You can get circulating immune complexes in 65 to 100%. And you can get a decreased serum complement level in 5 to 40% of these patients. Now, whenever we talk in terms of diagnosing an infective endocarditis patient, there's something called as Duke's criteria, there's something called as modified Duke's criteria, and there are certain modifications which we may need to understand. So when we talk in terms of Duke's criteria, sensitivity is approximately 76% in Western literature. The major deficiency is inability to diagnose blood culture negative endocarditis as far as Duke's criteria is concerned. And when we talk in terms of modified Duke's, they have added certain things which includes Q fever serology testing, staph bacteremia and the absence of other primary focus as a major criteria, and serological evidence of other organisms consistent with endocarditis as a minor criteria. So modified Duke criteria would include a positive blood culture, typical microorganism for infective endocarditis from 2 separate blood cultures. It could be viridans, it could be Streptococcus bovis, Hasek group of organisms, Staph aureus, or community-acquired enterococci in the absence of a primary focus, or persistently positive blood culture, which is defined as recovery of a microorganism consistent with infective endocarditis from blood cultures which have been drawn more than 12 hours apart. All of 3 or a majority of 4 or more separate blood cultures with first and last drawn at least 1 hour apart, and a single positive blood culture for Coxiella burnetii of phase 1 IgG antibody titer 1:800. Now, when we talk in terms of how to find any evidence of endocardial involvement, you get a positive echocardiogram, wherein you can document an oscillating intercardiac mass on the valve or supporting structures, or in the path of regurgitated jets or an implanted material, in the absence of an alternative anatomic explanation, or an abscess, or a new partial dehiscence of prostatic valve, or a new onset valvular regurgitation. Now, when you talk about new onset valvular regurgitation, simply an increase or change in pre-existing murmur is not sufficient. The minor criteria would include predisposition for predisposing heart condition or injectable drug use, fever, which is persistently more than or equal to 100.4 degrees Fahrenheit. You can get vascular phenomena in the form of major arterial emboli, septic pulmonary infarcts, mycotic aneurysms, intracranial hemorrhage, conjunctival hemorrhages, and Genevieve lesions. You can get immunological phenomenon in the form of glomerulonephritis, Osler's nodes, Roth spots, and a positive rheumatoid factor test. You can get microbiological blood culture, meeting major criteria as noted previously, or you can get a serologic evidence of active infection with an organism which is consistent with endocarditis. So at the end of the entire, whole thing, which I don't think you will be able to remember without reinforcement, what would be required would be either 2 major criteria, or 1 major and 3 minor criteria, or all the 5 minor criteria to allow a clinical diagnosis of definitive endocarditis. What are the other modifications? This is a 2015 modification from European Society of Cardiology. Now these are the modified criteria. So major criteria include blood cultures which are positive or from infective endocarditis from two separate blood cultures. You have got microorganisms which are consistent with infective endocarditis from persistently positive blood cultures. And that would include more than or equal to two positive blood cultures of blood samples which are drawn more than 12 hours apart, or all of three or a majority of more than or equal to four separate cultures of blood, with the first and last samples drawn at least more than or equal to 1 hour apart. Or you can talk about single positive blood culture for Coxiella burnetii of phase 1 IgG antibody titer, which is more than 1:800. As far as imaging positive are concerned, echocardiogram is positive for infective endocarditis, vegetation, abscess, pseudoaneurysm, intercardiac fistula, valvular perforation or aneurysm, new partial dehiscence, or you can find an abnormal activity around the site of prosthetic valve implantation, which is detected by a PET CT only. Only if the prosthesis was implanted for more than 3 months, or radiolabeled leukocytes by using SPECT or CT. Definitive paravalvular lesions on cardiac CT are again one of the imaging positive criteria for diagnosis of infective endocarditis. So what were the modified criteria for the diagnosis of infective endocarditis? These are the minor criteria: predisposition such as predisposing heart condition or injectable drug use; fever, which is defined as a temperature which is more than or equal to 30 degrees centigrade; vascular phenomenon, including those detected only by imaging; major arterial emboli, septic pulmonary infarcts, infectious myocardic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, and Janeway spots. Immunological phenomena such as glomerulonephritis, osseous nodes, straw spots, and rheumatoid factor. We have got microbiological evidence in the form of a positive blood culture but does not meet a major criterion as noted above, or serological evidence of acute active infection with organism which is consistent with infective endocarditis. Now, I do agree that this can be very confusing when you are going to sit down and discuss this and talk about it. So my suggestion to you would be probably to go back on the net, go back to your books and look at the criteria. Probably going through them repeatedly would help you into remembering them faster. Now, this is the algorithm for diagnosis of infective endocarditis. You've got a clinical suspicion, you've got a modified due criteria,